I'm going to give an overview of the neuropathology of Parkinsonism and Parkinson's disease. So I want to introduce my perspective, and that when we talk about Parkinsonism, we're actually talking about a clinical syndrome that has a variety of underlying pathologies. The clinical syndrome's quite familiar to many of you in the audience. It's characterized by bradykinesia and a host of other features, such as rigidity, axial instability. And one thing that's characteristic of the disease, in the end stage, it leads to a debilitating state. And at this end stage of the disease, as many as 80% of Parkinsonian patients will have dementia. What I'm going to talk about is a molecular classification of Parkinsonism. Clearly, the most common Parkinsonian disorder is Lewy body disease, and Lewy bodies are composed of alpha-synuclein. But there are other synucleinopathies, if you will, in addition to Parkinson's disease, dementia with Lewy bodies being a major disorder, and multiple system atrophy. The other major form of Parkinsonism is associated with abnormalities in the tau protein, where abnormal deposits of tau occur in neurons and glia. The most common of the tauopathies is progressive supranuclear palsy, cortical basal degeneration being less common, and a type of Parkinsonian disorder that has drawn increasing attention to the public is chronic traumatic encephalopathy. There are a variety of other proteins that can accumulate in Parkinsonian disorders, and as one example, I'm going to talk about Perry syndrome. Perry syndrome is a Parkinsonian disorder in which TDP-43 accumulates. TDP-43 is the protein that accumulates in ALS, Lou Gehrig's disease, and in frontotemporal dementia. So Lewy bodies are defined based on inclusion bodies that can be seen with routine histologic methods, such as a hematoxylin eosin stain. They're eosinophilic and hyaline, and they preferentially occur in pigmented neurons. So this is a neuron that has brown pigment, that's neuromelanin pigment, characteristic of neurons of the substantia nigra and the locus ceruleus. There's debate in the literature whether the Lewy body is toxic in and of itself, or if it's an adaptive response of the neuron to other types of cell injury. One thing we do know is that the neurons that are vulnerable to Lewy bodies eventually die, and they'll leave Lewy bodies in the extracellular compartment where that neuron once resided. The other thing that we're increasingly aware of, and not so readily detected with routine histologic methods, is the fact that there are abnormal axonal profiles, or neurites, in Lewy body disorders, and also Lewy bodies in neurons that were not previously thought to be vulnerable, such as cortical neurons. They look quite different from the classic hyaline brainstem type Lewy bodies, and these are sometimes referred to as cortical type Lewy bodies, and much more difficult to detect with routine histologic methods, but they're very easily detected with synuclein immunohistochemistry, which is the most specific and sensitive method for detecting Lewy body pathology. So you see the difference between the hyaline Lewy bodies and the cortical type Lewy bodies. But what synuclein immunohistochemistry reveals is that the Lewy body is really just the tip of the iceberg. The major abnormalities in synuclein in the brain are not the Lewy bodies, but these abnormal neuritic profiles that are invisible with routine histologic methods. And when people report that there's poor correlation between a given clinical feature and Lewy bodies, it could be because the Lewy body is only part of the story, and that you really need to look at those correlations with respect to the entire burden of abnormal synuclein. It's been presented at this meeting already, the seminal contributions of Heiko Brack and his colleagues in terms of proposing a staging for synuclein pathology in the setting of Parkinson's disease, where the initial pathology begins in olfactory bulb and lower parts of the brainstem, with eventual progression in a rostral-caudal manner, with the end stage of the disease associated with widespread cortical Lewy bodies. Kosaka had a similar classification in which he described brainstem predominant Lewy bodies, limbic or transitional Lewy body disease, and then diffuse Lewy body disease. So I will often be referring to diffuse Lewy body disease, which basically corresponds to Brack's stage 6. Now, certainly the Parkinsonian clinical syndrome is characterized by bradykinesia and other hallmark clinical features, but there's many non-motor manifestations of the disease that may actually be precursors to the eventual Parkinsonian syndrome. And in fact, Bill Langston had this review, a commentary in Annals of Neurology, where he described the extrapyramidal motor syndrome as the tip of the iceberg, and that the actual Parkinsonian syndrome included a variety of these other clinical manifestations, such as sleep disorder, autonomic dysfunction, hyposmia, and in the end stages of the disease, psychiatric manifestations, and even dementia. So in fact, if you look at the autonomic nervous system, there's two major types. The components of the autonomic nervous system is the thoracolumbar sympathetic nervous system, and there's a craniosacral parasympathetic nervous system, and then this is where the preganglionic neurons reside, and then they project to the postganglionic. And what I've circled is what the areas in the nervous system that have been documented to be affected with Lewy body pathology. And suffice it to say that it's not only neurons in the central nervous system that are vulnerable, but also the ganglion cells and their neuronal processes in the periphery. So at the end stage of Parkinson's disease, if patients live long enough and they have the right risk factors, they will develop a cognitive disorder. As I mentioned, the Sydney longitudinal study estimated that up to 80% of patients eventually, if followed long enough, develop dementia. But the other disorder that's been debated in terms of its relationship to Parkinson's disease dementia is dementia with Lewy bodies. The primary clinical syndrome in dementia with Lewy bodies is dementia, and these are patients that present to behavioral neurologists or neurologists that specialize in cognitive disorders rather than Parkinson or movement disorder specialists. They have a number of overlapping clinical features, but dementia is the number one clinical feature of dementia with Lewy bodies, whereas bradykinesia and other motor problems are the characteristic features of Parkinson's disease with dementia. And this is described here in terms of by Netter, the classification. There is memory loss in the Lewy body disorders, but it tends to be different from an Alzheimer type Lewy body. Alzheimer's is characterized by an encoding deficiency, whereas the memory deficits that are seen in the Parkinsonian disorders are more those related to retrieval. They have visual spatial deficits that can be quite obvious, and for example, even on the MoCA exam, you can detect significant difficulties with the drawing part of the MoCA exam. They have psychiatric features, visual hallucinations, well-formed, non-threatening hallucinations, delusions. One of the characteristic features of the delusions is the Capgras syndrome. I don't know if you're familiar with this. This is where the individual denies that their spouse or close significant other is somebody other. They recognize them as their spouse, but they don't realize that is in fact their spouse, and this is called the Capgras syndrome, and it's very characteristic. RBD, REM, rapid eye movement, sleep behavior disorder, is another feature that's characteristic of the Lewy body dementias, and this in fact can antedate the cognitive or motor syndrome by decades. There's one patient in our longitudinal DLB study at Mayo Clinic that had 50 years of RBD before developing cognitive problems and then eventually dementia. The Parkinsonism is different typically in Lewy body dementia from that seen in idiopathic Parkinson's disease, in that it tends to be an akinetic rigid, and it's often not as asymmetrical. The distinction between DLB and PDD is the one-year rule, but I would just emphasize that the new criteria stipulate quite clearly that the one-year rule is used for research purposes alone, and that the diagnosis should rest on what the primary clinical presentation of the patient is. Was this a patient that had established Parkinson's disease and then later developed cognitive problems? That's PDD. Was this a patient that had early cognitive deficits with or without Parkinsonism? And Parkinsonism is actually not a required clinical criteria for DLB, in which case the diagnosis would be DLB. So in terms of the underlying pathology, Lewy bodies are the sine qua non, without which it's not. You need Lewy bodies to have a Lewy body dementia. They're usually numerous, they're usually widespread, they correspond to Brock stage 6 or to Kosaka's diffuse Lewy body disease. A subgroup of patients also have Kosaka's transitional or limbic Lewy body disease, which would be Brock stage 4 and 5. The pathology, as I mentioned, includes neurites in addition to Lewy bodies. And the one thing that's eminently clear in neuropathologic studies is that these are mixed disorders. Only 10% of them are pure Lewy body disorders. The majority of them have concomitant Alzheimer pathology, either in the form of many amyloid plaques with sparse tangles or full-blown Alzheimer's disease in which they have plaques and tangles. The Consortium for DLB recognizes the mixed nature of the pathology in this disorder and proposes to classify the individual according to the distribution of the Lewy bodies, brainstem predominant, limbic, or diffuse, and to also characterize the degree of Alzheimer pathology using a Brock neurofibrillary tangle stage, where low is minimal neurofibrillary tangles limited to the medial temporal lobe. Intermediate has neurofibrillary tangles affecting limbic structures and early neocortical involvement. And Brock stage 5 and 6 are neurofibrillary tangles that are widespread throughout the neocortex. And what has become clear is that the likelihood that the patient actually presents with a DLB syndrome is directly proportional to the severity of the Lewy body. So the diffuse Lewy body cases are more likely to have DLB syndrome than brainstem. And it's inversely related to Alzheimer pathology. The higher the Alzheimer pathology, the less likely the patient would present as DLB. And that's because the Alzheimer pathology, if you will, trumps the synuclein pathology. And the majority of the patients with high Alzheimer type pathology actually present as Alzheimer's. And in fact, Alzheimer's disease is in fact probably the most common of the Lewy body disorders. So how well do these criteria work? This is a prospective cohort that included individuals before they died with a diagnosis of probable DLB or probable AD. And you can see the ratios that the 13 of those with DLB as an antemortem had actually fall into this category here. So the criteria work quite well when in terms of the cases with minimal Alzheimer pathology and transitional or diffuse, they in fact do have a DLB syndrome. And it works pretty well in excluding these other disorders. So the majority of the patients, well, about 50% here, have Alzheimer as their clinical phenotype. And here, it's 27 out of 34 had a DLB. So there's a significant number of individuals here that had an Alzheimer phenotype, not DLB phenotype. And what we've discovered is if we divide this into 5 and 6, most of those ADs, clinical ADs, are in this Brock stage 6. So there could be some revisions of these criteria to make them better, but they work pretty well, actually. So I want to move on to multiple system atrophy. This is another synucleinopathy. It's usually a sporadic disorder. There are very few examples of familial. There's very few genes. There's CoQ10 that's been implicated in Asian studies of MSA, but it hasn't been found in Europeans or in North American. The sine qua non for the clinical syndrome is autonomic dysfunction. These patients have to have autonomic dysfunction to meet clinical criteria. And then they can either have a progressive ataxia syndrome, cerebellar ataxia, or a levodopa non-responsive Parkinsonism, and that defines MSAC and MSAP. There are actually some differences in the prevalence of these two disorders. MSAC is more frequent in Asian populations. This has been confirmed in several studies. MSAP is more frequent in European and North American populations. And although rare, there are some patients with MSA that have a clinical syndrome that's quite different. They can actually present as a frontotemporal dementia, but this is really a rare type of presentation. The most common findings with macroscopic examination in MSA with Parkinsonism is degeneration of the putamen, the posterior putamen, posterior and lateral putamen, and the substantia nigra, where there's severe loss of pigment in the substantia nigra. The hallmark histologic feature is the glial inclusion, what are referred to as glial cytoplasmic inclusions described by Papp and Lantos, originally with ubiquitin and then subsequently shown with synuclein immunohistochemistry. These are filamentous aggregates of alpha-synuclein in oligodendrocytes. Most patients with MSA do have neuronal inclusions, and some of them may actually resemble Lewy bodies, but they have very different distribution. They're prevalent in the inferior olivary nucleus, in the medulla, the pontine nuclei, in the pontine base, and in the putamen. Those are areas which you never, if you looked at Brock's scheme and looked at where Lewy bodies, those are not areas that are vulnerable to Lewy bodies. So the synuclein pathology in neurons affects a completely different population of neurons. In our brain bank series and a study led by Shunsky Koga, he reviewed the clinical records of patients that were correctly and incorrectly diagnosed with MSA. And we started with 134 with clinical diagnosis of MSA. And the majority were correctly diagnosed. 83 of the 134 were correctly diagnosed with pathology. But then there were a number of other disorders that mimicked or masqueraded as MSA. And so Shunsky has organized the clinical features and neurologic signs in this table, which you can see from his original publication. But just the bottom line here is that when MSA is misdiagnosed, or when PD and DLB are misdiagnosed as MSA, it's because of the autonomic dysfunction. And this, as I think clinicians are becoming increasingly aware, autonomic dysfunctions are common in Lewy body disorders. They shouldn't necessarily make one think about MSA as a clinical syndrome. And when our PSP patients were misdiagnosed as MSA, it was because of neurologic features that were characterized by ataxia. And this is becoming increasingly understood as well, that some PSP patients may have cerebellar signs. And again, for some peculiar reason, this is also more common in Asians. So the original reports of PSP-C or PSP with cerebellar syndromes or cerebellar ataxia were from Niigata. And it's much less frequent in the United States and Europe. But these are three disorders that can be misdiagnosed as MSA. This was our Brain Banks, a retrospective series. Very few of these individuals had antemortem MRI or other imaging studies that might have helped in terms of differential diagnosis. But the way medicine is practiced in the United States is imaging might be done when the patient first presents, but then later on in the disease course, as other features evolve, imaging is not usually done on a practical basis. And so at a point where the diagnosis, maybe there's a question in the diagnosis, and imaging might help in terms of the differential diagnosis, it often is not done. And I think it's worth considering the value of follow-up imaging on clinical patients when there's anything that doesn't quite fit with what your original expectation was. I want to turn to Parkinsonian tauopathies and discuss three main Parkinsonian tauopathies: progressive supranuclear palsy, cortical basal degeneration, and then CTE. The tauopathies are all associated with accumulation of tau protein in neurons and glia, and they're due to selective accumulation of abnormal forms of the tau protein that can be detected with biochemical methods if you homogenize brain tissue and then look at insoluble proteins. The 3-repeat prevalent tau are these forms of tau, and these accumulate in Pick's disease, which I'm not going to discuss. The 4-repeat taus have alternative splicing of exon 10 that give 4 repeats in the microtubule binding domain, and they have this pattern. And then the 3+4 have all 3 bands. This is characteristic of Alzheimer's, type tau, and also chronic traumatic encephalopathy. So we can subdivide the tauopathies into 4R and 3R+4R. PSP is the most common of the atypical Parkinsonian disorders. It presents with unexplained falls. It has axial rigidity, dystonic posturing, a fairly low frequency, and there's a known genetic risk factor. There's a common variant in the MAP gene that is the most common genetic risk factor for PSP. The patients have difficulty with looking up and down, particularly down gaze. Up gaze is less specific, especially in the elderly. There's some neuroimaging characteristics, such as this, what's referred to as the hummingbird sign on a sagittal MRI, which reflects atrophy of the midbrain. The pathology of PSP can actually be diagnosed with macroscopic examination with almost 100% accuracy. There are three characteristic features. There's atrophy of the midbrain associated with loss of pigment in the substantia nigra. There's marked atrophy of the subthalamic nucleus, and the outflow pathway of the cerebellum in the superior cerebellar peduncle undergoes extreme atrophy compared to the control. And microscopically, you can confirm this, but in fact, there are macroscopic features that make the diagnosis. This is a neuronal and glial tauopathy, so we see tau tangles in neurons, as well as astrocytic lesions and oligodendroglial lesions. The pathology, the regions that are most vulnerable, globus pallidus, subthalamic nucleus, and substantia nigra, and a variety of other systems, especially extrapyramidal systems, are vulnerable as well. I just want to point out that this superior cerebellar peduncle atrophy is actually an early feature, and we've looked at a series of controls, and they're usually around 3 to 4 millimeters in diameter, and in PSP, it's about half that thickness, and in fact, it can be seen as early as 3 years after the initial onset of symptoms, and it decreases throughout the course. So there are some structural changes that can be used to follow the course of the disease. PSP can have atypical presentations. We usually think of it as a symmetrical disorder, but some of the patients have asymmetrical clinical features and may have cortical features, and they actually get diagnosed as corticobasal degeneration. Some of the patients with PSP actually have a levodopa-responsive syndrome, at least initially, and this is referred to by Williams and colleagues from the Queen Square group as PSP Parkinsonism. Corticobasal degeneration is a rare disorder that's infrequently accurately diagnosed clinically. In our brain bank series of pathologically confirmed corticobasal degenerations, the clinicians get it correct 40% of the time. Not even flipping a coin. Flipping a coin would do better than making a diagnosis of corticobasal degeneration. And the most common syndrome is a progressive asymmetric rigidity and apraxia syndrome, sometimes called Paris syndrome. There are a number of other clinical features that are characteristic of the corticobasal syndrome, such as cortical sensory loss and alien limb. There are actually other presentations, progressive aphasia, frontal dementia, and PSP. So corticobasal is usually asymmetrical, but sometimes corticobasal is a symmetrical disorder, and those patients get misdiagnosed as PSP. So just to reiterate, corticobasal syndrome is the clinical syndrome. The underlying pathology is corticobasal degeneration. And this is a 4R tauopathy that has overlapping features with PSP, but it's distinct. There's far more thread pathology. This is tau accumulating in neuronal processes in CBD compared to PSP. And there's more white matter involvement. If you look at a cortical area, such as the motor cortex, there's almost equal abundance of abnormal tau accumulating in the cortex as the white matter, whereas in PSP, it's predominantly the gray matter. I want to just briefly touch on chronic traumatic encephalopathy. This is a syndrome associated with repetitive subconcussive and concussive head injuries. It's a lot of interest in this in terms of sports, and the clinical features include Parkinsonism, but also behavioral features that can somewhat mimic a frontal lobe dementia syndrome. The pathologic lesion of CTE is accumulation of tau at the depths of sulci around blood vessels. And we've actually investigated the frequency of CTE in our brain bank. We identified from chart review 66 patients that had exposure to athletes of one form or another, of athletic involvement of one form or another. And then we did immunostaining for tau protein. We matched them to non-athletes and included some female controls. There's very few reports of CTE in women, but presumably there's no reason why they shouldn't be able to have this pathology as well. We screened our sections, and then when we found on our small sections pathology, we had whole mount where you can see very clearly the epicenters that are characteristic of CTE right at the depths of sulci. So we found about a third of the individuals that had been exposed to sports, especially contact sports, had pathology of CTE, and football was the most frequent. In the 198 individuals, both males and females, that did not have exposure to contact sports, none of them had CTE pathology. This shows you the level of expertise, the severe pathology in a boxer and in a professional football player. But we also found fairly advanced, and this is a staging scheme proposed by Ann McKee for CTE. We found stages 3 and 4 in people that had only exposure in high school or in college. And my last two or three slides, I want to talk about Perry syndrome. This is, and I just want to include this because this is an example of a TDP-43 proteinopathy that can cause Parkinsonism. These are patients that present a variety of ways. In fact, one of the most recent patients I've seen was actually seen by a pulmonologist for a patient that had central hypoventilations of unknown etiology. Eventually died and had TDP-43 pathology. But they also have Parkinsonism. Depression is a very severe clinical manifestation, and sometimes patients actually commit suicide. It's such a severe problem. The brain macroscopically looks fairly normal until you section the brainstem. You see loss of pigment in the substantia nigra reflecting the Parkinsonism. They don't have Lewy bodies, they don't have tau pathology. They have TDP-43 inclusions in neurons. This is neuromelanin pigment in the substantia nigra. That's not a Lewy body, that's not a neurofibrillary tangle, that's TDP-43 inclusions. They're in cell processes, they're in glia, and they're in axonal spheroids as well. So what I've told you about is that Parkinson's is a clinical syndrome complex that has a range of clinical pathologic entities, that neuropathology can help to understand the complexity of Parkinsonian disorders, and that we can use molecular classification to try to understand Parkinsonian disorders. And the simplest way to classify them in terms of molecular pathology is based on the synucleinopathies, the tauopathies, and TDP-43 proteinopathies. There may be others in the future as these disorders are studied, but these are the main types of Parkinsonian disorders at present. And I just want to acknowledge the number of individuals that have made contributions. I've mentioned some of them, particularly the neurologists that are involved in caring for patients that are actively enrolled in autopsy program. And I'll conclude there. Thank you for your attention.